Good morning. I'm Ed Israelski. I'm hoping my slides will magically appear. There they are. And I will also be talking about human factors. It's a term that has a lot of synonyms. I'll mention some of them in a moment. Human-centered design, human factors, usability engineering, among the many variations on that. I've been involved with human factors for quite a while, over 40 years in the telecommunications industry, and now the last 15 for Abbott and AbbVie, and heavily involved in standards in this area, both at the international level with IEC, ISO, and domestic standards from AAMI, the Association for the Advancement of Medical Instrumentation. Now I've semi-retired to some part-time consulting. So I have a definition that I think is harmonized with Irene's of human factors engineering or human-centered design. There are a lot of these definitions. This one says that what we're doing is we're taking data on human capabilities and limitations and applying it to the design of things. And when we say things, it could be a pretty broad set of things. It could be labels, packaging, smartphone apps, medical devices, combination products, device-drug combinations, websites that support this. Anything that has a user interface where the human has to interact, get information from the site, process it, then act, is fair game for this field of human-centered design and its many synonyms. We rely heavily on the methods of the behavioral sciences, some of which Irene just talked about. I'll supplement that. And the goal is to make, in the case of medical products and all the things related to it, like websites and smartphone apps, and risk communication information that's part of that, make that efficient, safe, easy to learn, and easy to use. So some of the synonyms that have been out there, and by the way, this, for those of you who don't know, the field human factors has been around for 60+ years. It started in World War II as a result of new systems being rapidly deployed and failing, not because of engineering problems, but because of a poor mismatch of the users and the user interface, not taking into account capabilities and limitations. So psychologists and engineers got together in World War II, and that's when the field was first created and given the name human factors engineering. Subsequently, these synonyms have come about. In some ways, its origins can trace back to industrial engineering, where people studied time and motion and things of that sort. But human factors broader, looks at all the things that humans do, the cognitive components, perception, and action. So ergonomics, that's a term that you probably have heard a lot, ergonomically designed furniture, ergonomically designed cars. And in the United States, when we talk about ergonomics, people focus on the physical interaction, forces, grip, matching body size, hand size. There are these other terms, usability engineering, user experience design, user-centered design, so on and so forth. For our intents, all purposes, we're talking about the same thing. A lot of good products in the medical field have employed human factors. The FDA requires it. To get a CE mark in the European Union, you must follow the international standards on human factors. I have a slide at the end which lists some of these for your reference. This is now a regulatory requirement. There's also many companies in the United States who have human factors professionals who are trained. You can get graduate degrees in this field. I have one. A lot of companies employ human factors people. Microsoft has 250 people, Yahoo, Amazon. There's been a long tradition of automobile companies having people with these kinds of backgrounds. Typically, people get into it by being sometimes engineers, and then they get interested in the behavioral sciences and go back to school. That's my case. But sometimes people start off in psychology, want to apply it to real-world problems and get into human factors that way. It's multidiscipline. We have a lot of people who come from clinical backgrounds, physicians and nurses, communications backgrounds, who get into human factors. Kind of a wide open field in that sense. There is a certification that a few people have gotten. Here are some products, though, that have won awards for their good user interface design, human factors design. On the upper left, there is an insulin calculator glucose meter that's smartphone-like, taking advantage of the fact that now people are more familiar with the user interaction with gestures and pinching and swiping. And so this is what modern technology offers us, and it gives us some advantages in terms of user interface design. There's an infusion pump in the middle there that won several awards for its user interface work and its human factors research that led to that. It's a large format, 8¼ inch diagonal color touchscreen that uses Windows-like conventions, scroll bars, drop-down list boxes, radio buttons, pop-up dialog boxes. And it was pioneering in that it introduced that into the space of infusion pumps and won awards for it. But you can have some simple things. On the far right, we have the IV pole. This one won awards because it was stable, had places to store things like oxygen, and two poles, so more things could be mounted more easily, more stably. On the far left, packaging. This is a baby formula where the packaging design is ergonomically and it has good information on the outside and some tear-off information about preparation of baby formula, an easy-to-access scoop to mix things, to not waste powder. And then the one down the bottom in the middle is a video-aided device for intubation, for visualizing the vocal cords before intubating a patient. So good practices can be done. The contrast on this is not as good as I would hope, so I apologize for that. But this is another way of looking at the human factors, human-centered design process. Starting at the upper left, we have what we in the field call contextual inquiry. This is understanding three things: who the users are, the user profiles, as Irene described, their capabilities and limitations, not just their demographics. Also, what environment will they be using this product in, whether it's a web app, a smartphone app, a package, a label, or instructions for use, or risk information that's trying to be communicated, or where are they using this? In a brightly lit condition where there's a lot of distraction? Are they in a cramped workspace? These are important things. Are they wearing eye protection that could interfere with their ability to read, or other personal protection equipment that needs to be taken into account in the design? And then the third element of contextual inquiry, understanding the context of use, is what are the tasks and the scenarios of use? What are the sequences of things that people will do? And you want to document and describe all this, because this is the foundation for your design. The next thing that we have to do for medical devices and combination products, drug packaging and labeling, container labels, is do formal risk analysis. Look at all these tasks that we know have to be done. Try to assess what could go wrong, what mistakes could be made. The term of art in human factors for medical is use error, not human error or user error. We don't want to blame the user. We observe that an error occurs during use, and we want to understand why. It could be the design, or it could be a failing of the person. They're tired, they're stressed, and this causes the problem. But we need to understand that. So you look at formally and systematically each and every task, what could go wrong, what are the consequences, the harms that could result, and then you prioritize your design work based on that. And later, when you do some validation testing, you'll use this risk analysis to pick out the most critical tasks that you need to be sure are tested, to be sure that improvements, mitigations that you've made, in fact, work. And these are all iterative. I've simplified this diagram by taking out a lot of the feedback loops. This risk management gets done early and then repeated as you learn more as the design unfolds from its early prototype stages to be farther advanced. The next is you specify what the user interface should be, and that could be what's the layout of the navigation of a smartphone app, or the layout of the instructional materials, including the risk communication materials that's inside them. So you specify that in great detail. So there's a little room for creativity on the part of the development team who actually creates these things. That you've done this upfront work, you specify what you want in the user interface. Ultimately, what you're going to when you're going to judge that whether you've met the user interface requirements, what's your acceptance criteria? For safety and critical tasks in the United States, the FDA is looking at that as being qualitative, because it's very difficult to get precise human factors measurements unless you do huge studies with thousands of people, which are not practical or affordable. So it's mostly a qualitative exercise. For business and marketing reasons for products, you can do quantification. But the focus is on qualitative. The next thing is you do this hard work, the iterative design, rapid prototyping tools, where you can change things easily when you do your early formative testing. Irene talked about that a moment ago. These are early usability tests where typically one-on-one you observe people doing these tasks that you learned about in contextual inquiry who are representative users and are doing it in a simulated environment that is reasonably close to the one they'll actually be performing these tasks in. So you do this early work called formative because you're forming the design, and then you get to a point where you feel that you can do validation or a summative usability test at the end to show that all this work that you've done cumulative to this point now is going to pay off, and that you'll be able to meet your acceptance criteria and have a product that meets all your user requirements. It's safe, effective, again, applying broadly to a variety of things. So the critical steps, this upfront contextual inquiry to understand the tasks, the users, and the use environment, doing risk analysis and repeating it, focused on use error, prototyping, iterative design, and testing. It's possible to come up with an early design based on, even if you did all this upfront work very well, you still would learn things in usability testing that show you that your design is not doing everything you had hoped it would, and that you need to make improvements and modifications. And that's just the nature of the way design work occurs for all these things. We don't have sophisticated technology to let you design a user interface right from the beginning perfectly and it'll work for everybody. Only through testing will you learn and iterate and make improvements. And then there's post-market analysis as well. You can learn a lot about things that didn't necessarily show up in your early work here, but they do show up when the product is launched, and then you can take corrective action. Irene mentioned this formative and summative, and so did I. And the formative is great for doing things like looking at alternatives, looking at what obstacles are in the way to achieve your usability or acceptance criteria, and to see if they in fact are obtainable. And then summative is done at the last stage with production equivalent. This is the product you're going to launch, and this is the one you would subject to summative validation at the end of the design process. Best practices in usability, you want to be sure you have representative users, not just people who are convenient. They need, if they're patients, that they have the characteristics of the product that's going to be used. So if the patients have hand dysfunction due to rheumatoid arthritis, or they have vision impairment due to diabetic retinopathy, that these people are included in your testing. We talk often about having distinct user groups, and there's an art to defining them, but the notion is that they have different risk levels and different tasks, they tend to be distinct user groups, and we focus on the testing to involve the appropriate distinct user groups. Good examples would be patients versus nurses versus physicians, 3 clearly distinct user groups. But within those groups, you can have subdivisions, again, based on the tasks they do and the risks. You want to give them real tasks to do, especially the ones we call critical tasks that are related to safety, not just convenient tasks to give them that you can easily measure and feel good that people can do them, but if they're not the critical tasks related to safety or the ones that are essential to getting the product used correctly or the risk communication material conveyed correctly, then you're fooling yourself by not testing the real representative task. Realistic use environment, using the real product or a reasonable simulation, and early on, it's very appropriate to use 3D parts printed things for things that are physical, or computer simulations for things that are screen-based. You can learn a lot with these very early, crude, sometimes crude simulations. One of the other hallmarks of usability testing is the bottom one. They ask people to think aloud in a formative study where you learn a lot. You can get some good insight when people are interacting with a product, whatever it is, and as they're doing things, you are encouraging them to explain what's confusing them. Where are they tripping up? So we call that Think Aloud protocol, and it can be very helpful. in understanding what's going wrong in the design and where are the opportunities for making changes. So, summary is this human factors engineering process for medical products of all sorts that I described is systematic and scientific because it's got these things like contextual inquiry, some usability goals, user testing with iteration. For medical devices and the device part of combination products, we have to follow rigorous design controls, which are specified by regulatory agencies like the FDA. You have to maintain a good design history file that is auditable. You have to do formal risk management. You do things like verification and validation of your design along the way, and an important component is post-market surveillance. Getting toward the end. So I mentioned that there are, besides the FDA guidances that Irene mentioned, some standards that are, I think, even if you're not designing medical devices, they're valuable to read because they tell you about the principles of human factors in some detail and how you might apply them to things like testing, risk communication, success. Because it's another set of tasks that people have to do. They have to understand interactions, that they can't take certain foods with their medications, that they need to take precautions about driving or other daily life activities, and how is that communicated best to people. So the principles that are in these standards can help in that area. So the top one is the domestic standard, AAMI, the Association for the Advancement of Medical Instrumentation. ANSI is the American National Standards Institute. And this is a 500-page standard called HE75 with the title Human Factors Engineering, Design of Medical Devices. It's got a companion book that supplements it of 850 pages. And that seems daunting, but this is a field with a lot of literature. It's been around 60 years, a lot of books, a lot of master's theses, PhD dissertations, quite a few journals. So this is a distillation by experts from the AAMI Human Factors Committee. And there's a second edition of this standard coming out. And it's divided into 25 sections with titles, oddly enough: packaging, labeling, the use of symbols, controls, displays, alarms, integrated solutions like mobile, portable devices, hand tools. So it gives you a lot of valuable getting started information. You wouldn't necessarily take everything that's in this standard and apply it to the particular product you're designing, even if it is just a piece of paper of instructions or the labeling on a package. But it's a great starting place because it takes the literature in human factors. We've studied things like the size of characters, the contrast ratios, brightness levels of displays that work. You don't need to reinvent the wheel. You can go back and find the literature in this area. And this standard also has an extensive set of references, so you can go in and learn even more if what you see in the standard isn't enough. And then there are two recently issued standards on the international level that are also domestic. Their full title is ANSI, AMI, IEC 62366 Part 1 and Part 2. They're also ISO standards as well. The title doesn't reflect that, but they're joint standards between ISO and IEC. And I'm the co-convener of the group that has put these standards together, and we continue to evolve them. The first international standards actually came out on human factors, usability engineering, which is the preferred international term, in 2004. So none of this is new, but these are now getting more modernized, and they're reflecting more contemporary human factors language and usability engineering language. So the first one, application of usability engineering to medical devices, is a process standard. It elaborates on that flow chart that I showed and the points that Irene covered earlier, and it's normative. It has shall statements in it saying you must do these following things, like you must do risk management, you must do usability evaluation of some kind. Part 2 came out this year, 62366-2. It's a technical report from IEC, and it's a tutorial about all of the methods of human factors, and we've only touched on a few here, the core ones, but there are quite a few others, probably 30 or so, that are described, pros and cons, where you might use them appropriately in the design of different products. Again, the focus being on medical products here, but can certainly be used beyond that. And it's quite a bit longer, and it gives you a lot of advice on with should statements rather than shall statements, because it's a tutorial technical report that this -2 is in support of the -1 standard. And then there are the FDA guy. FDA recognizes all these standards, by the way, from AEMI, from IEC and ISO, and the FDA has been very heavily involved in the writing of these standards. They've been committee members for a long time. Actually, the original international standard that came out in 2004, the convener of the joint working group that did that was Peter Carstensen, an FDA human factors person who was one of the first human factors people at the FDA. And so there's been a great effort on the part of the FDA to be involved in these international standards, which are applied around the world. And then there are the standards that Irene talked about, the CEDAR ones, the combination product at the bottom, and then CDRH, the device people, have a guidance that just came out in this year in February that elaborates more on the expectations from the FDA on application of human factors to medical devices. So those are the prepared materials that I have, and I'm right on time, apparently. All right.